Good morning, everybody, and welcome to this session, implementation of new guidelines and penetration of access to care in bariatric and metabolic surgery. I am chairing this session with Scott Sikora, current president of the Federation, professor of surgery on Harvard, and what it came quite clear over the last few months is that we do a lot of progress in evolving and improving the knowledge of new technique and new indication for bariatric and metabolic surgery. But the reception at European or continents and national level, it often is not parallel, is not easy. In other words, we do a lot of improvement, but these are not, they are not received at the level of the surgeon and patient care. So this is the aim of this session, and so I ask Scott if you want to say a few words and call Nicola Di Lorenzo to start to introduce the topic of this morning.
Well, welcome everybody. This has been a passion of mine and throughout my career, that those old guidelines were outdated, they discriminated against our patients, and we never seemed to be able to topple them. That the insurance companies in the United States and maybe some of the health ministries around the world were holding on to them like you couldn't believe because it saved them money. And we finally broke through this year, working together with our partners in the United States, the ASMBS and IFSO. We were able to come up with guidelines that are based on data, that are fair, that improve access. And we're seeing in the United States, insurance companies adopting it now, which has never happened before. So if I get a little emotional when I present it, that's why. I mean, this has been my ambition for a long time, was to break this, and we finally did.
Yeah, one of the problems is that we are getting old, we get emotional.
That's right.
but this is also part of the sentiment and the passion that we put in our daily work. So let me start with Nicola Di Lorenzo. I beg the speaker to be quite on time, quite direct to the message, because the final idea is that we are going to steal a document at the end of this session that it will be offered to the Italian authority and perhaps to the authority of other countries that are would be willing to do so. So Nicola Di Lorenzo is professor of surgery in Rome, and he's the current president of the European chapter of the International Federation. Nicola, please.
Good morning, everybody. We will stay the rules we decided with Luigi and Scott, and the concept is to give an introduction about the benefits and the needs of bariatric surgery. Of course, I cannot talk about the benefits and the needs all over the world, so some things will be related to Italy because it's a case, or Europe. No conflict of interest, this is my case mix. Obesity is an illness. This is important to keep in mind. We all know in the room, but this is needed to be stressed by all the organizations, WHO and so on. It's a disease, and we have to treat the disease. The mortality risk is, as illustrated here, is raising much with the raise of BMI. And I will give you the figure of what happens in Italy. This is a summary of what has been taken by the SICOP, the Italian Society, about the number of centers we have, the distribution, which is uneven. As you see, most of them are in the north, while obesity is more frequent in the south. This is a problem all over the world. The number of procedures performed, again, uneven respect to the regions. But just to give you an overview of what happens in our country. So what are we as surgeons? We are not this, we are not this. We are performing something which is helping people with obesity. But bariatric surgery must be performed in centers with a group with a specialized activity. What are the benefits? in very summary, we can speak days about this. I think that this whole work by Christou is still good in describing the relative risk reduction of all the problems you see listed here, but mainly the mortality of the people among the surgical group and the group of control. You see how important is this ninefold reduction of mortality. And the results in some of our studies, Maurizio De Luca will speak about that later on, the cost-benefit ratio is in favor of bariatric surgery. So it's also a fact that it's very well demonstrated how important is bariatric surgery. But with the advent of COVID, I can show you a case from Italy, and I think in all over the world it happens the same, that of course we know that obese people have a higher risk of having a very severe COVID, as it's shown in this French paper. But when we evaluated what happened in Italy during that time, we saw a 30% reduction of the procedures because we didn't, what was stopped immediately was bariatric surgery, which is in a sense incredible, but this is what happened. And this is what happened through the months. You see that in March, April, May 2020, we almost stopped the procedures, then we restarted in summer, and again with the second wave, we stopped again. This is against the rights of a patient or people with obesity, because they have the right to solve their problem, to reduce their risks. So there is a missing consciousness of the role of bariatric surgery in healthcare, at least in Italy, but also I think in the other countries. What are the needs? Quickly. It's a complex problem, interconnection among patients and structures, transforming therapeutic alliance, all things that we know. How can we solve it? In Italy and at least in Europe, we have a breast unit model thanks to a famous Italian surgeon. All over Europe, we have a legislation concerning the breast units. If you change a breast unit requirements with 3 clicks on PowerPoint, you can create an obesity unit. This is simple on PowerPoint, more complex, but this is one of the goals we have to work for. Now, this is Italian, sorry for this, but these are some points that are the same as everywhere. Now, the system for reimbursement, the DRG system, has been calculated 20, 30 years ago. Nothing changed. So we have the same money. We have new procedures which are not considered. So things must move ahead in Italy, in Europe, or in the world. There are 4 simple goals, which is the end of my presentation. One is the obesity to be included in Italy, but all over the world, in the essential level of assistance, which is something which exists in many countries, which is describing the right to have the same level of cure for all the citizens of a country. And this is not at the moment in many, many countries. Second one is the update of reimbursement, which is important as well. Third one, to create the obesity unit, which I mentioned before. In some countries they exist. They exist in real life, but do not exist in the legislation. Fourth, to have a dedicated budget for this surgery. In many circumstances, if you have a limited budget, when you arrive to September, emergency or oncology come first and you stop the obesity program. This cannot happen anymore because the right of people with obesity must be respected. Thank you very much.
Thank you very much, Nicola. Message very clear, 5 point, 1 slide, 5 point, everything I think got the message of this presentation. And now is Scott. Scott is going to present, Professor Shikora, the new guidelines, so the evolution of our knowledge over the last 30 years on this topic.
Thank you very much. If we could have my slides, I'm going to explain. Closer. Okay. Unfortunately, for those of you that are younger than 31, you may not get all of this, but I asked a very simple question. Do you remember things that happened in 1991? For instance, Dances with Wolves was the most popular movie and won the Oscar. Next, please. And The Cat in the Hat, those books, the children's books, well, the writer, Dr. Seuss, died that year. We had the Gulf War in the United States. And I got out of the residency program and I went into the United States Air Force. And the vice president at the time told the world he invented the internet, which I don't think he did. The Soviet Union broke into 14 countries. And what else happened? The US National Institute of Health developed guidelines for bariatric surgery based on old data, based on bad data, and decisions made by non-surgeons on how surgeons were going to practice. And the remarkable thing is 31 years later, we're still using them. There's nothing else in medicine as far as treatment guides that we're doing that's 31 years old. Many things have changed since 1991. The phones, robotics, electric cars. We'll move on from that one. Cardiac stents. But what hasn't changed? What has changed? Increase in the incidence of obesity, more operations that we have to our availability, dramatic safety, and yet the insurance companies and the payers still look beyond this. What hasn't changed since 1991? The National Institute of Health 1991 guidelines on bariatric surgery. So let me tell you a little bit about it. They decided in '91 that they were going to do a formal consensus development conference. They took a bunch of medical doctors, researchers, scientists, one surgeon, created a panel of 20, and they went ahead and they reviewed the data in the literature at the time. At that time, very few cases were done around the world. A busy program maybe did 100 cases a year. It was all open gastric bypass and open vertical band gastroplasty. There was no lap band, there was no robotics, there was no laparoscopy, and those were the only operations available. So in the literature, there were very few papers with very little data and not good data, and that's the only thing they had to them. But they relied heavily on body mass index, and this is what they came up with, that if your BMI is under 40, you had to have comorbid conditions. If it was 40 or above, you can be considered for surgery even without health conditions. You had to repeatedly demonstrate that you failed medical therapy, and you didn't have to have any major psychiatric disorders. And this has been around all this time. And this is very interesting because they dabbled in creating guidelines beyond '91, but they never got anywhere. But look at what I highlighted. That's the words of the FDA, of the National Institute of Health itself, saying some of the material is likely to be out of date and at worst simply wrong. And they published this saying their guidelines were wrong. And that was the meeting they had. Their data was not supported by current literature. It wouldn't be. Again, there were no lap bands, there was no laparoscopy, there was no sleeves. So it was a different data set than where they are now. The bottom line is that your guidelines need to be the intersection between risk and benefit. We have the benefit, they had the risk. 30 years later, they're still there. So that was the reason we decided to get rid of them as best we could and to establish guidelines that were more database, best practice, and not just what a bunch of scientists and medical doctors put together. And I'm sorry if I'm going a little fast, it is a time constraint. BMI is a very poor surrogate for adiposity. These three people all have almost the same BMI, but obviously Shaquille O'Neal has essentially no body fat. The woman in the middle is more classical what we see, but this is why BMI just doesn't work, because it isn't a good indicator of how much adiposity one has on their body. We know, particularly with the Asian community, that BMI discriminates against ethnic groups, it discriminates against gender, against age, body habitus, and that's what the FDA was using. Since that time, there have been other guidelines created by other groups. I highlighted that for you, and in yellow was when they partnered with a surgical group such as IFSO or the ASMBS. So what did we do? Well, this was a passion of mine for years, and when I became president, I said, this is what I want to tackle this year. And interestingly enough, Dr. Shanu Qatari, who was the president of ASMBS, had exactly the same issues and the same interests. We met and we said, let's work on this together, the two societies, the ASMBS representing North America and IFSO representing the rest of the world. And together, we put together a writing group that included members of both societies. We identified issues we wanted to address. We went back to the good literature, the new literature, the randomized trials, the meta-analyses, and all this data we never had before, and we went through it looking for how to write up the guidelines as they should be. And we wanted that there would be science involved with a little bit of opinion, as opposed to 91, where it was a little bit of science and experience and a lot of opinion. And this we came up with were guidelines that were not based on body mass index solely, but was based on benefit. And these are the 11 points of the criteria that we came up with that would mean a patient should be eligible for surgery. And we were able to demonstrate out of 9 of these that we had statistical significance, that surgery was better than non-surgery. On 2 of them, which is the arthroplasty and for BMI less than 35 without comorbid conditions, we could not do a normal analysis of it because there wasn't enough data in the literature. So we put that through what's called the Delphi method, and we demonstrated strong consensus amongst experts with those. And basically all of 11 points that you see here should allow your patient to have surgery if they have any of these. So the new guidelines were made to accommodate the differences in gender and age and weight and the other things that we had seen the 91 criteria had no effect on. Paper 2. Going back now, we don't want to be criticized by anybody else stating that our data wasn't strong data. So we set out recently, a group of us, to look at our data, to perform the meta-analysis and to perform the systematic review under the leadership of Dr. DeLuca, and we're hopefully going to be able to demonstrate again in writing that we had very good data, real data, statistically clean data to prove all of these points. And if so, then there should be no further argument. And this is what we did. We were able to demonstrate the reasonably high level and grade of all of our data. As you could see, no C's, no D's, no 4s, no 5s. So we were able to demonstrate that we took good use of the literature and we proved our point. So in conclusion, the current 1991 criteria for metabolic bariatric surgery served us well in the past, but it's long outdated, it's no longer relevant, and it should be out of here. The literature is quite clear that metabolic bariatric surgery is considered for several categories of patients for which it was denied in the past. The new guidelines reflect the current state of the field and the current state of the literature, and it's therefore necessary and appropriate to retire the 91 guidelines. Let's say goodbye and wave to it as it leaves and implement this. Now, what's happened in the United States with this? 14 insurance companies that were following the 91 guidelines converted over and are following our guidelines. 14, and that's only the beginning. In addition, we published simultaneously the results in both journals, SWORD and Obesity Surgery, and ASMBS took the lead on publicity. There were multiple interviews done with members of our team that made the newspapers and on the radios and televisions back in the United States. So we now have guidelines. Even if they deny a patient and you call them up and say, I have a patient, can we discuss this patient? They're giving in to us way more easily than they ever did before. So this is a huge victory, but we got to keep going. We're not done yet. And with that, I just want to thank you for the opportunity to present. I'm sorry I had to rush through it, but it's tough to talk about a topic like this in 10 minutes.
Thank you. I leave the podium to Professor Di Lorenzo to continue with Maurizio De Luca, please.
Thank you, Luigi. Thank you, Scott. Excellent. Thank you so much. You showed very well how hard you work in the last years. Maurizio De Luca is the next speaker. How to implement the new guidelines and improve access to care in the Italian national health system, cost, utility, and bariatric surgery.
Thank you, Nicola. Okay. So I go quickly ahead because I see we are a little bit late. So what about the national health system principles? First of all, universality. All the organizations related to the national health system must guarantee in a uniform way the essential levels of assistance to the population. Equity, all the citizens must be guaranteed equal access in relation to the equal health needs. Equality, some citizens who do not belong to the category of the national health system are required to pay a ticket. And reality, there is a different organization through region for public hospital and private affiliate facilities with the national health system, and obesity, as we said before, in Italy is not considered in the essential levels of assistance. What about the Italian situation regarding bariatric and metabolic surgery? In 2022, we had more or less 24,000 operations done. This is the registry, Italian registry, and with inequality in terms of geography. These are the Italian center of bariatric and metabolic surgery, and as you can see, the majority of them is in north of Italy. In the detail, you can see that there is one region, which is Lombardia, who has the majority of the centers and at the same time the majority of the operation. Second place is occupied by Campania. And then there are other different situations in different regions. So also in this diagram we can see the inequality of the situation. I work in northeast of Italy, in the Veneto region. I have to say that we have a model who could be considered a benchmark. Because with this network for this region give us the possibility to speak in many obesity centers with the same language regarding the indication, regarding the perioperative treatment, regarding post-operative treatment. So a sort of network regarding only this center in this specific area. What about the cost? The total cost for an operation is very difficult to evaluate. We can see that the preoperative assessment is only 100 euro, but it's exclusive, of course, gastroscopy, liver ultrasound, respiratory instrumentally test. Operating room is 2,200 to 1,800. Surgical team costs 1,400. Hospital stay, if we consider 3 days, is 600 for a total of this cost. But the reimbursement is different, as you can see. It's different in the different region in Italy, as you can see in these slides. And of course, the balance also is different because thanks to this movement of patients, there are some regions who have an active balance and some other regions who have a passive balance. So the reality is then, since obesity is not in the LEA, public bariatric centers receive less economic and political support. Since the reimbursement is high, private and affiliated facilities have a high interest in bariatric surgery, and due to the different organization and availability through Italian regions, there could be a high rate of itinerant patients. So, how do we connect the guideline with the Italian system? Professor Shikora told before me about the ISMBS IFSO guidelines, but we need to consider our guidelines, the Italian guidelines. This is the item of the ISMBS IFSO guidelines, international guidelines, that have some shared items with our guidelines, 2016. But considering the law of 2017, we have the possibility to consider another reimbursement for public and private hospital only with the new kind of guidelines, with the law who started 2017. The new guidelines in Italy are very severe. They have to respect, yes, we have to respect a methodology which is the GRADE methodology, which is a very severe methodology that we adopted for our Italian guidelines. And as you can see, in the majority of recommendation of the international guidelines, we have a share with the Italian guidelines. So at the end, the Italian guidelines, in the majority of the case, can accept the recommendation of the international guidelines. So consequently, we can say that obesity is not considered today in the LEA. Reimbursement for public and private hospitals depends on the acceptance of these guidelines, which are to an end, we hope by the end of September, and implementation will be harder for affiliated hospitals. Thank you.
Thank you. Thank you, Maurizio, for your presentation that is exactly addressing the process of how an international guidelines is going to be received at the national level, because this step is not easy, it's the first step. And afterward, there is the topic and the task of transferring all this new bunch of knowledge to the local, regional, political organization to implement the access of care to obese patients. So now is a very special opportunity for all of us, because we have an extraordinary privilege, a great honor of receiving the visit of the Minister of University and Scientific Research, the Italian Minister, and she's Anna Maria Bernini, came from Rome to present her witness and to show that she is very close to the task that we are addressing with the entire Congress and with all our daily routine work. Please, Minister Bernini.
Thank you so much. It is my privilege. I'm glad to be here, and thank you for your kind hospitality. And first of all, talking about thankings, I would like to thank the Congress President, Professor Luigi Angrisani, for his kind invitation, and the IFSO President, Professor Scott Shikora. I also thank and greet Professor Nicola Di Lorenzo and Professor Marco Zappa. And I thank IFSO Chief Operating Officer, Manuela Mazzarella. I greet the representative of the Italian Minister of Health and of Region Campania. It is an honor for me to welcome all you researchers, professionals, and students in Italy. I know this event has been possible also thanks to the contribution and the effort of the Italian scientific community in this medical and research field. As a minister, as an Italian, I am proud. And I want to thank everyone who, at all levels, was involved in the organization and logistics of these days. Finally, let me thank all the participants who have chosen Naples for these days of symposia, expert talks, discussion panels, and many other interesting activities. The fact that you all are here, gathered together, it is very important for you and for us. The entire Europe, along the centuries, saw the blooming of intellectuals from many different countries, witnessing the birth of modern science. Here in Naples, your international community of experts has gathered from 93 countries. I was told more than 100 countries. Is it correct?
150 countries.
150 countries all over the world. Congratulations. Science develops also through precious moments of common sharing. Events like this are choral efforts for the general well-being. In this occasion, you address a fundamental disease phenomenon that silently undermines the health of many countries. According to World Health Organization, most of the world's population live in countries where overweight and obesity kills more people than underweight. The advancements in metabolic and bariatric surgery and your daily effort show us that high-end technological capacities paired with quality research really can benefit every field. As you experts have demonstrated, for instance, the valid answer provided by minimally invasive surgical approaches benefits from the robotic-assisted procedures. And even AI, artificial intelligence, and computational models are to be considered as useful tools. Being here among you, I cannot help but cheer the improvements enabled by your research. You're offering solid, life-saving solutions for millions of patients. But I would also try to remind the potential solutions that Italy has been working on. As a ministry, we are supervising and implementing our part of the Italian National Plan for Recovery and Resilience that devotes a significant amount of resources to innovative research in different medical and surgery fields. However, change needs to be structural. The operative and research dimension of countries' medical capacities need to be reinforced at their foundations. Overweight and obesity are on the rise in low and middle income countries, especially in urban settings, as you know. Globally, obesity has almost tripled since 1975. And on the other side, shrinking demography and aging populations pose a serious threat to the stability of many Western countries. Such phenomena reflect on the impact that chronic diseases have on health systems. Moreover, the combined effects of overweight on life expectancy, health expenditures, and labor market will shrink the gross domestic product by the 3.3% on average in Organization for Economic Cooperation and Development countries by 2050. This is a heavy burden for the future of our countries. Italy is getting ready to tackle these challenges, and you're a demonstration of this challenge. A few months after the government was sworn in, we established a working group tasked with planning the raise of a number of students for the restricted access courses in medicine and surgery in our domestic medicine faculties. Soon, we will have 4,000 more students with a total aim of 30,000 more in next 6 years. Along with the Minister of Health, Professor Orazio Schillaci, we also started to address the issue of postgraduate specialties courses. Future research improvements start with the possibility for more willing and determined students to fulfill their talents and vocations. Funding research means more effective treatments and a better quality of life for patients and their relatives, on whom a large part of the daily hard care work waits. Moreover, I think that a change is needed also in cultural terms. Patients need to trust scientific evidence, and so to choose surgery when it is needed and it represents the most appropriate treatment. At the same time, science has to adapt to the pervasiveness of today's information streams. An effective communication of science saves lives. Information and prevention can avoid deaths from chronic diseases like the ones you're addressing. Research institutions need to focus on new ways and approaches to share the evidence of their research and, when it's needed, to directly join the debate to correct misleading interpretations and representations. It is a shared and civic duty for every scientist in every country. I know that IFSO, through its global registry and annual report, is doing its part, together with its partners, for instance, here in Italy, the Italian Society of Bariatric and Metabolic Surgery. As data points out, in the last decades, overweight and obesity have become a worldwide issue. The evidence strengthened the need for international scientific cooperation. Italy, my ministry, and Italian university and research system are truly devoted to the empowerment of a more comprehensive scientific diplomacy. You are part of it. Lay new foundations, and we will help you build solid synergies. The lifelong example of Professor Nicola Scopinaro and of his discoveries in this field reminds us that a single researcher can make a difference, and that science lives also through intuition and curiosity. I would like to thank you once again. Moments like this are crucial for policymakers to acknowledge the frontiers where research has led us in the struggle for the well-being. I am sure then that during these days you will be able to experience the outstanding hospitality of Naples while discussing the state of the field, enriching your knowledge and mutual understanding, and building enduring scientific connections. Best wishes for a very fruitful and stimulating Congress. Thank you.
Thank you. Thank you very much, dear Minister. And it is my privilege on behalf of the International Federation and also on behalf of...
I have to say IFSO or IFSO? What do you prefer?
Well, we say IFSO.
IFSO, okay.
And, but that's mine. On behalf of IFSO and on behalf of the colleagues, the many colleagues that are here, I would like to donate to you a medal as a symbol of your participation to, if you allow me, I'd like to.
It's beautiful. Thank you so much.
I'm not sure if it's your style. To me, looks very nice.
It might be my style. Thank you.
whatever looks very nice on beautiful women. So
Thank you. It's very kind of you. Thank you so much. Can you see the medal? Okay.
thank you very much.
Thank you so
It was a
much.
lovely participation, beautiful talk. We will continue, we hope to continue our relationship with your institution. Thank you very much. So let continue now the journey that where we were tackling this morning with Juan Pujol, that is going to present what is the state of art of the guidelines across the countries all over Europe. Please, Juan.
Thank you, Luigi, for giving me this lovely opportunity of being here, and congratulations for, looking this synergy with policymakers and the world of medicine, surgeons, etc. I think it's the clue to fight against this plague of obesity. Do I have the pointer? Okay. So I have no conflict of interest to report regarding this speech, unless, except that I am a bariatric surgeon. I'm supposed to talk about the survey that IFSO is doing, investigating about bariatric and metabolic surgery indications and coverage worldwide. So what's the world doing? Because we know that since the 1991 National Institute of Health Consensus Conference, new procedures have been introduced, and laparoscopy has replaced open surgery. So all we know that surgery today is much more effective and safer than before. So if the safety profile improves, the indication criteria should be and could be expanded. And that's why over the last few years, different medical societies have widened their recommendations for bariatric surgery, opening them towards lower BMIs. And it has been done progressively. The American Society have published several papers, and IFSO as well, the American Diabetes Association, etc., trying to open and give opportunities to more obese people to benefit from bariatric surgery. And finally, the American Association, altogether with IFSO, published the latest recommendations and indications for bariatric surgery last November 2022. Now the point is, due to the diversity of national societies that make up the IFSO, the indications for surgery at the national level may not perfectly follow these recommendations and may change from one country to another. And so knowing how metabolic surgery is indicated in different countries is an essential step for IFSO to propose future strategies to update them and, if necessary, standardize indications worldwide. So having this in mind, IFSO launched a study aiming to analyze the national recommendations, which are the national recommendations for metabolic surgery in IFSO member countries, and to what extent they are aligned with the international recommendations. And a second goal, the study aims to assess how metabolic surgery is financed in each country and whether it is covered by its public health system or not. So this way, a questionnaire was developed using an online platform in order to obtain this information and the type of financial coverage they have in each country, either public or private. This survey was sent to all IFSO member national societies. It was sent between December 2022 and July 2023. In case of non-respondents, a maximum of 8 reminders were sent, and in case of vague or unclear answers, one of the study co-workers, co-authors, recontacted the respondents in order to clarify the doubts. So now we are going to present those data collected between December 2022 and July 2023. This data is analyzed as a whole and also grouped according to the different geographical chapters that the Federation have. And these are the results. We got a nearly 90% response rate, which is not bad, so it's significant. And when asking if their national society do have any recommendations or guidelines about indications or candidates for bariatric and metabolic surgery, 70% of our national societies said, yes, we have our own guidelines, but there's still 1/3 of our members that have no guidelines at all. And this difference, this data is not statistically significant difference between the different chapters that IFSO Federation have. When asking which are their guidelines, there's still 20% of our members, those who have guidelines, 20% that are still stick on the old 1991 guidelines. There's 1/3 that have already shifted to the newest 2022 guidelines. And finally, half of our members are somewhere in the middle. What does somewhere in the middle means? Well, some countries have recommendations halfway between those of 1991 and those of 2022. These are the guidelines that have been published a few years earlier by the ASMBS or IFSO, European chapter, etc. For example, including to the old guidelines, those type 2 diabetic patients with BMI, lower BMI. When asking if their national public health system financially covers metabolic bariatric surgery, 65% of the countries do cover, but there's still bariatric surgery is not covered by public health system in 35% of the countries that make up IFSO. And if we group them in the different geographical chapters, there's no association, statistical association between the chapter and health system financially covering metabolic surgery, but this tendency exists. So it seems that in the Middle East and Latin America, there are fewer countries where bariatric surgery is covered by the public health system. And also, I have to say that in many countries that do cover metabolic surgery, is not universal. In many countries, insurance coverage also limits those who can undergo surgery. For example, there's a study that demonstrates that in states, less than half of pediatric cases, approval was granted upon initial request for coverage, whereas payers initially approved most of the adults who met similar criteria. And the reason for denying surgery is just the age below 18 years old. And in other countries, such as Korea, the Netherlands, metabolic coverage is limited to patients elder than 18 years old. So it's not fully coverage. So in conclusion, we can say that most of IFSO member societies do have metabolic guidelines with no metabolic surgical guidelines with no difference between chapters. 22% of them have already shifted to the most updated American IFSO 2022 guidelines. But there's still 43% of countries in our federation with, who are still stick on the old 1991 guidelines or without any guidelines. And there's still 35% of IFSO member national societies where metabolic surgery is not financially covered by the public health system. And I have to say that most are in the Middle East and Latin America, where only 37% of their countries cover metabolic bariatric surgery. So as a closing remarks, I would say that IFSO is doing a lot of work to disseminate the new clinical guidelines. but we must continue to encourage some national societies that make up IFSO to develop or to update their clinical guidelines. And we also need to intensify our contact with insurance companies, policymakers. That's why I'm very happy to be here. And congratulations, Luigi, for your great idea. And also healthcare payers to seek global coverage. I don't want to finish my talk without remembering all the people that is collaborating with the survey. Thank you for being here, of course, and remember that the next IFSO European Chapter Congress will take place in the lovely city of Vienna next May 2024, and you're all invited. Thank you very much.
Thank you very much, Juan. You don't mind if I tell you that this is the best presentation I ever heard in my life on this topic. You covered the entire world, and you have given us very important information that that should be used at any level. So can I have the last but one slides of Juan with closing remarks? Because I think that slides is going to be previous one, the previous one. Yes, I think this is one of the final message of this session, but it gives me the opportunity to open now the discussion. So I invite the panelist, Maurizio, that is Italian, as you know, in Paulina from Finland, Rezi Adib from Australia, and Rachel Button from UK. Will you please to sit in front and perhaps start some discussion? Before opening the discussion, Paolo Gentileschi, will you please to go to the podium and briefly address the message of the Italian Minister of Health, Orazio Schillaci. So we were very privileged this morning in this session to have also that the Minister of Health has asked one of our colleagues to present his message and support for this. So Paolo, briefly address the message of the Minister of Health, and perhaps if can we have some flying microphone, please?
Thank you, Luigi. The Minister of Health in Italy is a good friend of mine. He was a former dean and rector at the University of Rome Tor Vergata, so we used to work for more than 20 years together. So being not able to come today, he asked me to read his message to this conference, and I'm going to do it right now. I would like to give my best greetings to IFSO in general and to Professor Angrisani and all participants in the World Congress of IFSO. I strongly want to express my sincere gratitude for your professionalism, skills, and passion you put to study and improve scientific and clinical knowledge in bariatric and metabolic surgery. I am deeply aware that the increasing prevalence of obesity in Italy, the risks for our patients related to serious comorbidities, and the severity of this chronic disease associated to diabetes, pulmonary diseases, cardiovascular, and cancer, with a strong impact on health costs. All this represents a very important challenge for our scientific community and Italian institutions. We are all active to guarantee to obese patients the access to health care and to the best multidisciplinary therapy based on new drugs and surgical procedures. These 3 days in Naples represent an important occasion for a multidisciplinary meeting of obesity experts, the introduction of new guidelines about bariatric and metabolic surgery, indications for surgery in Italy. The new guidelines and the new indication for surgery have the potential to improve the management of this disease in our country. At the same time, we need to implement all measures to change this trend and to reduce obesity prevalence, especially in young people. Our task as a Minister of Health is to promote a culture of prevention of obesity, therapeutic changes in lifestyle, eating behaviors, and physical activity. I'm sure that this Congress will give us important insights and suggestions. Good work to all of you. Thank you.
Thank you very much, Paolo. So, of course, you stay here into the discussion with the panel. So now we start, I think we start to hear the opinion of the panelists, the comment of the panelists, because one of the tricky problem that I addressed in the executive board, and Paolina was just following me in this, is okay, we do very nice new guidelines, but how these guidelines penetrate at the national level? So I took few people all over the world to bring the witness, how does it work in their country? Please, Paolina, can you start?
Thank you very much, Luigi. And I think the topic, I would perhaps start a bit from a bigger picture, because implementation of these new guidelines is, of course, one part, but it's like a huge puzzle that we need to build piece by piece, because we have to remember that we have a chronic disease that has access to treatment from 1 to 2%, and even lower in some countries. So everything we do in order to increase that access to treatment, whether now we have the new medications, we have surgery, we have a lot of the tools, and we do have to work with the politicians, as I think was a very good example of today that we had the Ministry of Health here. So really, we need to work on very many frontiers. And of course, like Luigi said before, and nicely outlined by Juan, is that the situation is very different in different countries. But I think this is, again, I would go for a lot of the collaboration between IFSO and also within the medical societies to work together, because we don't have to reinvent the wheel. We have some good practices all over, so I think we need to learn from each other. So it's like 1 + 1 = much more
Yeah,
than
but
2.
Paolina, the world is quite different. If we ask Anna Maria Bernini to talk with the Minister of Research in Finland, I don't know.
I fully get
they
it. The world
talk
is
the
very
same
different,
language.
and it's not the same recipe for everything, but we do have some good practices and experiences that I think we should benefit. But again, I think collaboration is the key issue here, and we just need to start building the puzzle piece by piece. That's
Rachel.
what I would say.
So the UK reimburses bariatric surgery. At the moment, it's based on the older guidelines. Is it working? There we go. But less than 0.1% of people have surgery. And that's because the public don't realise the health benefits of metabolic bariatric surgery. And they don't realise that obesity is not their fault and that it's a chronic disease. So in order to get people to embrace surgery, to ask for it, and healthcare professionals, we've got a lot of education to do. But we have really good data now for the health benefits of bariatric surgery, and we need to get that out. We need to explain to people that this reduces deaths, reduces cancer, reduces heart failure, heart disease and strokes, and really get the public health message out about if we treat people with obesity, then we will save lives and save complications. And I think that's one of the key things, that yes, we can have it funded, and it is funded, but people don't know about surgery. And the average GP doesn't know about surgery. They still see it as something dangerous, that's open surgery. So we need to do a lot of education within medical schools and the public.
So Rachel, you are saying not only we need to fund to receive the new indicator, but we need to communicate, to educate the medical community, otherwise it still will remain a barrier. Okay, let's move to Reza from Australia. What is the situation? Let's say that here in Europe, Paolina and Rachel, and of course Maurizio and Juan and Paolo, we work in let's say National Health Service style of program. So when we talk of Australia, I don't know how does it work.
Well, in Australia, we have a two-tier system, two systems running parallel to each other. We are having dialogues, as Rachel said, with the hierarchy about implementing and introducing the progress in the guidelines and asking to introduce and widen the bariatric surgery in our public health system. But we have a very unique approach that we have done for the last 20 years that might be interesting to all of you. In Australia, about 35 years ago, we introduced something like a retirement fund that every employer in Australia has to contribute 10-11% of the salary of everyone who gets employed to a retirement fund. We in Australia, we call it superannuation fund. That is to everybody who has a job in Australia, even if they don't have private health insurance. On the other hand, the incidence of bariatric surgery is about 90% in private sector, 10% in public sector. So 20 years ago, we approached our hierarchy, people in charge of the government, and said, how about we show you the data that if we allow these people who meet the consensus of the criteria, and they're not going to make it to the retirement age, they're not going to become 65-year-old, they're going to die at 45, 55, and before 65. We allow them to access that kitty, the retirement funds, when they are young, and we can show you how many years we can add to the life by allowing them to access that. So what happened? About 20 years ago, we started allowing people, of course, there's a lot of barriers they have to jump through. They have to be assessed. They have to be shown that they've dieted for enough and had conservative management for a while. So we started, while we were still negotiating for the public system, but doing our best and introducing them. In the private sector, we started saying, would you allow this man with a BMI of 50 access his retirement fund? And in the meantime, we started as surgeons negotiating with our hospital and said, these are my results, thanks to our very good registries that we have in Australia. This is my result. This is what I've done for the last 10,000 cases. These are my leak rates. This is my problem rates. We think if you allow them to come to private hospital for 2 days for this operation, or sometimes 1 day, we think the chances of them having a problem in the first 72 hours is this much. So we buy them a mini insurance for the danger period of their operation. And allow me to tell you, this works. Allow me to tell you, this system, while we're doing the other system, this system, thanks to a lot of people who spend a lot of time, thanks to registries who showed good numbers, I can turn around to my private hospital and say, listen, I just drove from the registry, these are my numbers, these are my leak rates, this is the chance of this patient will have to go back to operation theater for a bleed or for a this or that, and would you allow me to do this operation? And I can tell you, we are creating pretty okay numbers, like in my unit, in the private hospital I'm working, we're doing 1,800 bariatric operations per year.
So, thank you, Reza. So we are introducing another delicate topic that it is very hot in Italy. In Italy, over the last 5 years, we have had a tremendous shifting of bariatric and metabolic surgery from the public sector to the private sector. So this is another new information we are getting. Thank you very much, Reza. Juan, tell us something based on Spain experience.
Okay, Spain experience, I would say that it's very good, and the National Health Service works very well. So that means that the bariatric surgery is covered, but obviously this is universal. We are operating less than 1% of those people who deserve, not only in Spain but all around the world, can we reach the 100% of those people that need this operation? Of course not. If we aim to double the numbers, would be okay, but it would still be 2% of the people who deserves.
But that's very nice, Juan. But what is the barrier? You say it's covered. So what is the barrier? As Rachel
The barrier
and
is,
Paulina is saying, is knowledge or is funding?
I would say it's economical. It's very expensive to, because we don't know exactly. I do not have the numbers now, but I can imagine that to maintain the public health service is quite expensive everywhere. If you want to have a perfect medical service, it's quite expensive, and everybody of us know how much taxes do we pay for it. So could you imagine to cover it 100 times more? And we know that bariatric surgery is quite expensive. It's complicated. It has a lot of tools, and so it's not easy. I would say that, for example, guidelines, if we stick on guidelines, it's quite easy to change from the old one to the new ones. And we have already done it. In Spain, in the Spanish society, we have already shifted to the new American IFSO 22 guidelines. So we already have them. Are they applied in the everyday work? I don't think so, because there are preferences and there are patients more need for bariatric surgery. So those who are lower BMI probably and unfortunately will have to wait.
Thank you. Thank you, Juan. Paulina, quick comment.
Yeah, I have a quick comment because Finland, of course, has a similar governmental healthcare system. I would kind of argue, Juan, I don't think the issue is money because bariatric surgery is insanely cost effective. The problem is that even though the surgery itself may seem like it's expensive, actually I was surprised to see the number you showed, Maurizio, for the price of the surgery.
But he's mentioning it's question of budgeting.
I know, but
So
but still, but when you look at
I'm
the
sure
end
that
of the
in
day,
Finland
you
still
end up operating
But
the
oncology has more budget than.
definitely, but by operating patients, we would save tons of money. So that's really for politicians, that I think that is the key issue, that they don't understand that this is actually the idea that we're stupid when thinking about money.
I don't want to say that politicians do bad work, but probably they are looking at the medium term and they look for probably they are not prepared to manage where to go and what benefits best at the long term.
They're looking for the next election. It's not the easiest way to see that you get it.
We are getting on a difficult.
Yes, I know, but I think that's a
now.
crucial point that you have to understand, that that's actually, we would save money by doing this.
Absolutely. Maurizio, please, we like to have your comment.
My comment is related to Italy. I had the opportunity to present our situation in Italy. And you know that we have not obesity level of assistance, and we would like to have them. So we have more or less the same problem. We know the problem of obesity, but politicians are a little bit far from this problem.
So Maurizio, let me ask you a question, and perhaps also Paolo. So you see in Italy still the situation that was a few years ago, because before the shifting from national to private practice, in Italy the waiting list for bariatric surgery was 6 months a year. Now we shifted from 208, when I was president of the Italian Society, 4,000 operations, to a current situation of 30,000 operations per year, and it's probably going to increase. So in Italy, I think there has been a change in the situation, which is the more hot problem of our situation in Italy. The waiting list, I don't think is not.
No,
anymore.
I think the waiting list is not the hot problem in our
So which
situation.
is the hot problem in your view?
No, I think maybe with the Italian new guidelines, with the law of 1217, something could change, because our minister declared that they can accept new recommendation only with these new types of guidelines. So as you know, we are completing the Italian guidelines with the severe methodology of grade, which should be accepted the next month. And we hope that with these new guidelines, as they suggested us, something could change. I want only to precise that the Italian guidelines that are where every recommendation is done by grade share 85% of the ISMBS IFSO guidelines. So
Thank you. Thank you, Maurizio. And now the other point, delicate point that I think was...
Luigi,
What?
may I say
No,
something?
no,
on
no,
this?
I'm asking to you. I'm asking, I have a final question, because what Nicola said, I liked very much. So do you think that due to your direct contact and perhaps our support with the Minister of Health, are we going to have a dedicated budget, dedicated fund on the Italian health system? Because we are part of general surgery budget. So are we going to have dedicated budget to bariatric and metabolic surgery? This is the question for you.
Well, I can answer by myself, not for him. I don't think so. It should be. It should be, but I don't think so. I don't think so. I think the hot problem in Italy is that the waiting lists have been really, I mean, there's no waiting list today in Italy, but because of private institutions that are connected to the health system in Italy. We have a very complex health system. We have public health systems. We have private hospitals which are connected to the national health system, so they get paid by the national system, and we had totally private institutions. So the problem in Italy is the access to public hospitals, which is still very difficult, and it's related to regions, because the majority of private hospitals are in the north of Italy, and people from the south need to go to the north of Italy to get the operation. So we should be able to guarantee what Maurizio...
More equal distribution.
A good distribution of centers in Italy, and Maurizio was telling that. And the other need we have is what you were saying. We need to have some budget dedicated to bariatric and metabolic surgery. That's what I'm saying.
I'm very pleased of this panel, and before going anywhere, please from the floor, if there are questions or comments from the floor, please, Francesco Papadia from Genoa, please go to the microphone.
Thanks a lot. I have a difficult question. Should there be a choice of operation according to BMI and comorbidity? Because I think this might be the elephant in the room. Not all operations are equal. And maybe some patients with lower BMIs fare better with some operations rather than others. What's your comment about it?
All right.
Yes, if you want, Francesco, there is no evidence for every kind of BMI that one operation is better than other.
I think Maurizio said it. I think I understand your question, but we are still lacking the data to have that kind of a decision.
Let's create some discussion. I think Rachel, that is the only medical person, can tell you that for low BMI, perhaps the best is giving drugs. So it's very complicated.
I know, but that's also one of the points, because reimbursement for the medications, and that actually for some people that has to be a lifelong medication. But maybe, Rachel, you want to comment on that?
I think what we need is just really great data. We don't have the data for what's the best treatment, and we need to have really good data collection, looking at complications, comorbidities, and show what the cost of not treating is, so that we have the evidence to say we're stopping all these other diseases. So what we need is really good data, so that in 10 years' time we can say this person would be best with this person would be best than that. And
It may
use a
take a lot
polymodal.
of time to do this.
Yeah, but if
And
we don't
while-
start, we're never going to get there.
Now, other question, please?
Good morning. I am Patricio Lamosa from Chile. I belong to the board of the Bariatric and Metabolic Surgery Society. And from the last year until now, we could make public funding for the bariatric surgery. It was done in a work that took at least 4 years, talking to many, many people, all of the authorities of the country. And I can say that there were two big problems that we had to solve. The first one was money. It's because they believe that it is much very cost, and they don't know that it's cost effective. And the second was a stigma. Definitely stigma is the worst, because everyone from doctors, surgeons from other specialties, politicians, and people, they believe that our patients won't be able to get the objectives of the surgery, and they will regain weight and will maintain being in obesity. But from the last year, we have a kind of...
Can I ask you the question? Make the question to the panel. Is it a comment or a question?
It's a comment. It's a comment. It's more a comment. I'm sorry.
No, it's
I think your comment is very good because you very nicely underlined the two main issues that we need to increase the knowledge that obesity is a chronic disease, to decrease the stigmatization, and that really this is an effective treatment that has huge cost efficiency also.
Yes.
So.
Actually, what I was going to say now, it's what we do is a partnership, a private-public partnership, where there are public funders that where the public insurance pays half of the surgery and the patient gets the surgery in private centers. What happened? The amount of surgeries doubled in 1 year. Doubled.
very good.
That's also with the Nordic countries. There actually is that possibility of having the
Yes,
aligned with the governmental
it's a
and
very
the
good
private
solution,
practice.
and all of the countries around
So
Chile are
thank
looking
you for bringing us new scenarios and possibilities. So we're going to the conclusion, and I please Scott to take the conclusion and the final message. I think one of the idea is this kind of implementation session is going to be standardized for IFSO future meetings wherever is going in the world, because it's going to address an organizational problem, a political problem that we also need to face as an international and national society. Scott.
Everybody here pretty much demonstrated today how different it is from one country to the next and from one part of the world to the next. But it doesn't mean we just accept it. The way we were able to push new guidelines, we need to push implementation of guidelines. We need to help the medical community as well as the government understand the importance of the surgeries. People die waiting to have their surgery, and that's unacceptable. So my word is that we keep fighting. We work as a team, as a family, because we're all in this together, and we all have the common goals of getting access to care for our patients.
Thank you, Scott. We keep fighting and we keep taking picture. Now all the panelists. Thank you very much.